this evening. I'm glad you popped in, learn more about epilepsy. My name is Ellen Baca, and I'm the Lehigh Valley coordinator for the Epilepsy Foundation. I live in the Lehigh Valley, but because of our capabilities with Zoom, we get people from all over the state, sometimes all over the country that can tune in. I saw that someone had lifted their hand, raised their hand. I can't answer your questions. If you have one, put it in the chat button. Oh, that was an accident. Okay. So let's get started. So the Epilepsy Foundation of Eastern PA, we're the local Epilepsy Foundation of America affiliate. You can see here the 18 counties that we service. Our mission is to overcome the challenges created by epilepsy through efforts including education, advocacy, and research to accelerate ideas into therapies. Like I said, I'm in the Lehigh Valley area. I serve Lehigh Valley and Poconos and Schuylkill and Monroe counties, but we have coordinators throughout the 18 counties that live and work in the community. So let me tell you about some of the programs and services we have. People wrote in to say that a lot of them are family members. So this is a particular interest to share this with you. These are just some of the programs that we have at the foundation. Project School Alert is when we go out to schools and we train teachers, school personnel, even students about seizure recognition and first aid. We love doing the students. They end up being very supportive of their classmate. First responders and law enforcement, we do trainings for them. We do transition services. So maybe I was dealing with someone recently. They were looking for what kind of things we have in the community that they can their adult child can take part in. So give me a call, or any one of us, we can help you with that, at least direct you as to some of the programs and services that we're aware of. We have support groups throughout the 18 counties. Some people have speakers that start out. We have community members that go, they might live in the Lehigh Valley, but they'll tune into the Lehigh Valley and Philadelphia and Lancaster. So everyone's welcome. And with Zoom, we're able to do that. So you could, all these things, you can go to our website and see all the programs and services, including all the different support group meetings. We advocate, we go to Harrisburg and advocate for changes, laws, where we do educational conferences and seminars. I have one coming up in May that's pediatric, and it's going to be in person and Zoom. We also have one at the end of May as well. We can get you information and referrals. What doctor, I live in this area, what doctors are available, things like that we can help you with. Camp Achieve is a program we love. It's the third, I think around the third week in August every year, and it's a sleepaway camp for kids ages 8 to 17. They get to do things like canoeing, rock climbing, under the supervision of many, many people, including nurses and doctors. So we really enjoy that. What's really great about that is kids can meet other kids with epilepsy, witness a seizure, and make lifelong friendships participating in that. We also have adult services and young adult retreats. Adult services like a wellness weekend, young adults. We tried to get everybody together to meet other people with epilepsy. It's not on here, but we also do, we love having volunteers. That's a great way to connect with other people in the community as well. So what should I know about seizure first? I'm sorry. Felt like I skipped something, I'm sorry. So why should I know about seizure first aid? Because anybody, anywhere can have a seizure. 1 in 10 people will have a seizure in their lifetime. 1 in 26 will be diagnosed at some point in their life with epilepsy. So you can help. You might witness one, and as a result of this training, you'll know what to do. Epilepsy is really common. It's the 4th most common neurological condition after stroke, Alzheimer's, and migraines. Approximately 35 million people worldwide are diagnosed with epilepsy, and 3 million in the US alone, maybe 3.5 million in the US are diagnosed with epilepsy. It affects 470,000 students in the US, and about 1 million older adults ages 55 and older are diagnosed with epilepsy. So, did you know that everyone can learn seizure first aid? Did you know that most seizures are not medical emergencies? A person may not be aware that they're even having a seizure. Seizures are not contagious. A person cannot swallow their tongue during a seizure. It's a medical disease like having diabetes. A person can die from a seizure. It's not very common. So, what is a seizure? A seizure is a brief disruption of electrical activity in the brain. So someone having a seizure, it can affect their movement, their behavior, their actions, and their consciousness. So people can have seizures where they're walking around, but they're still not quite aware of what's going on around them. So it's not just those big seizures that we see on TV. Some reasons people have seizures. You might have heard of febrile seizures. That's when a child reaches a certain temperature from a fever, they might go into seizures. You can see that in infants. Maybe drug use or alcohol withdrawal could cause a seizure. Near drowning or lack of oxygen. Cardiac event. So I knew somebody that had a seizure and they didn't have epilepsy. They just had a seizure because they needed a pacemaker. Metabolic disturbances, head trauma, brain tumors, complications of diabetes. These are all some reasons why someone would have a seizure. And the last one is because they have an epilepsy diagnosis. So, what is epilepsy? Epilepsy is characterized by recurrent, unprovoked seizures. It's the same thing as a seizure disorder. So in the previous slide, I said febrile seizures. Well, then that was provoked by a high temperature. But seizures, people that develop epilepsy or have epilepsy, they're having seizures with no underlying reason. And so people usually get that diagnosis when they've had 2 or more unprovoked seizures. So approximately 60% of the time people are diagnosed with epilepsy, the cause is unknown. And it's very frustrating for parents and loved ones when a doctor or neurologist says your loved one has epilepsy and you want to know why. And the doctor says, I don't know why, it's just they have too much electrical activity in the brain. But at 40% of the time, there are some reasons why seizures are happening to someone. They might have brain trauma, or they might have had encephalitis or meningitis. They might have had a brain injury at birth, like cerebral palsy. There might be some congenital malformations and maybe some genetic causes. So doctors look at seizures in 2 ways: generalized or partial focal seizures. Generalized seizures are seizures that happen through the entire brain, both hemispheres of the brain. So all the neurons are misfiring. So they can look like convulsions, like we see on TV. There could be just staring. The most common are absence seizures and tonic-clonic seizures. The focal seizures, we used to call them partial seizures, they involve a small portion of the brain. They might be aware, they might be impaired, and the symptoms are related to what part of the brain is affected. We'll go through that. So you might know some of the old terms. Partial seizures, we now call them focal seizures. Where is it happening in the brain? So you might hear a doctor say that. Generalized is still generalized. We used to say simple partial seizure. We now say aware. So someone is aware of what's going on. They just can't control it because they're having a seizure. We used to call complex. Now we call it impaired awareness. We used to call epilepsy a disorder. Now we're supposed to call it a disease, although I'm trying to get used to that. So sometimes people have triggers, not all the time, just sometimes people have possible seizure triggers. And the number one reason would be you missed your medication, or there's emotional stress, even good stress. like, oh, my daughter's getting married on Saturday. Sleep deprivation, hormonal changes, alcohol, drugs, missed meals, nutritional deficiencies, and sometimes specific stimuli like flashing lights, which isn't as common as you think it is. Hyperventilation or other stimuli. I know somebody who has seizures because every time they hear music. Hormonal changes, that's like a lot of times women have seizures around their period. A lot of times people, they've never had seizures, and all of a sudden they go off to college and they're doing some of these things that we're talking about. Sleep deprivation, they're trying drugs that they've never tried before, they're drinking, they're not eating the way they should. So that, that being combined, I've gotten phone calls from parents saying, why is my child suddenly in college with seizures? So most seizures are not medical emergencies, but they're scary if you witness them. So keep that in the back of your head. Most of them are not medical emergencies. All seizures, no matter what they are, they should be timed and documented. There's many, many drugs that can treat seizures. The doctor needs the full puzzle, the whole thing, to understand what's best for the patient with epilepsy. So anything that you can do, like timing a seizure, keeping a seizure diary, writing down what happened right before, during, and after. Then when you go to your doctor's appointment, you can present that information, and it will be very helpful. Even think about with the patient's or with the loved one's permission to maybe record it, and then you can bring that along to the doctor's office. So basic first aid has common elements, but it varies depending on where the seizure is. So if there could be no change in consciousness, altered awareness, or loss of consciousness. So the first generalized seizure, the Tonic-Clonic seizure, that's the most dramatic. That's what would happen. They might cry out because the air is leaving their lungs. They lose consciousness and they fall to the ground and they get really stiff. And then they begin the convulsions. They might stiffen their arms and legs and then have rhythmic jerking. Sometimes they lose bowel or bladder control. Sometimes their skin might turn blue. They're breathing, but they're not breathing optimally. So once that seizure's over with, they're going to go back to their normal breathing cycle. But you might see a little bit of that. So afterwards, you might see confusion, headache. Usually everyone has these. They're very tired. They need to take a long nap. They're sore because of their body shaking. And they might have speech difficulty. So you might want to ask things like, you want to give them a little time to get back to where they were before. And then you'll ask questions like, you know what day of the week it is, you know where you're at, things like that, to see if they're back to where they should be. So first aid for this, you're going to stay calm. You're going to protect their head you're going to protect them from potential harmful objects. So they're laying on the ground, they're moving and shaking. You don't want them to hit, a chair and hurt their arms and things like that. So you want to clear the way. Observe and time the event. Make sure the airway is not obstructed. Cushion and protect their head and turn them to their sides so that when they're having the seizure, they're not swallowing. So the secretions from their mouth have to come out, and want them to come out, not back. So you're going to put them on their side and protect their head. You're going to remain with them till they're fully conscious, and then just follow the seizure action plan. Everyone should have a seizure action plan, and that's basically, I think I go over this a little bit later, just documenting the medicines and what to do in case of a seizure. Never put anything in their mouth. Maybe if you're over 60 and tuning in, you could be like, we used to do that all the time. We thought that they could swallow their tongue. Well, don't put anything in someone's mouth. They could bite it off, swallow it, aspirate. They could bite your finger off. They can't swallow their tongue. They might bite it, and it might be, their blood there, but that's much better than than sticking something in their mouth and risking other things. They could lose teeth even. Don't restrain them from their shaking. You want to let it run its normal course. If you start to stop them from shaking, they'll get hurt even more. You want to let the body do what it needs to do all by itself. So let's just look at a seizure here.
When they're thinking of seizures, and that's the Tonic-Clonic seizure, or what we used to call the grand mal. It can also be on the other side of the coin, what we used to call petit mal, where all we're seeing is an absence of a person. They just go blank for a moment, stare off, maybe a little bit of movement. And so we have the huge range from the biggest, the strongest, the most worrisome for most people, the grand mal or the Tonic-Clonic, all the way down to a little bit of movement or simply staring.
So I'm getting ahead of myself.
When they're thinking.
Okay. I thought the next thing would be the petit mal seizure.
When they're thinking of seizure.
Oh, here it is. We used to call them petit mal long, long ago. Now we call them absence seizures. It's a pause in activity with a blank stare. They might roll their eyes. They might have a brief lapse of awareness. They might chew or pick at their clothes. These usually last 1 to 10 seconds, and it might be confused with daydreaming or inattentiveness or ADHD. Now this video, it doesn't have any audio, but you can just see how her eyes go off and she's back. It's just a second or two. So they're really easily missed. So after a generalized seizure, that's the whole brain seizure, the person might be drowsy, confused, sore, and have a headache. Give them a few minutes to get reoriented. It could take up to 15 or 20 minutes. Ask the person questions like, do you know your name? Do you know where you're at? A person often will need rest afterwards for the generalized seizure, but not these absence seizures. What happens with the absence seizures is someone has that brief seizure, that 1 to 3 second seizure, and then they're right back where they were before. It's like a light switch going on and off. But with the generalized seizure, usually afterwards, people are just zonked. They're so tired, they want to lay down and go to sleep. And keep in mind, they didn't know they had a seizure. They might wake up and see all these people around them, and they might be embarrassed, disappointed what had happened. You might want to keep a blanket handy because they might lose bowel or bladder control. You want to keep their dignity intact there. So, just have something, try to keep people, have people back off and let that person have a seizure. We don't want them, the first thing they see is a bunch of faces staring at them. Here's another generalized seizure, the whole brain seizure, myoclonic seizure. Those are like muscle jerks. It might involve the whole body or maybe just parts of the body. It often causes a person to maybe spill what they were holding, like a cup of coffee, they might spill it. It's a jerk. It may occur in single seizures or in clusters. I think, when you're going to sleep at night and you're laying there and you're just about to nod off and you have a jerk. Those are not seizures, I can assure you, but it's that's what it kind of looks like. So the jerky movement, those are myoclonic seizures. Atonic seizures, that's a sudden loss of muscle tone. It might cause an individual to collapse and suddenly fall to the ground. They usually remain conscious, but it happens so quickly. Usually they end up landing on their head, and people with these types of seizures normally wear helmets. And a lot of times people that have these types of seizures also have a bunch of different seizure types. So your loved one may have had a grand mal seizure, but they might also have these other types of seizures too. So this obviously is a very serious condition because you have to wear a helmet. So the first aid for these types of seizures, again, time the seizure, observe and record everything. Make sure they return to baseline where they were before. Make sure they don't have any injuries, and repeat any information they may have missed during a seizure. Like if they have those absence seizures or other seizures that we're going to talk about, you want to fill them in with what they missed because they're not fully conscious or aware. How are we doing so far? Okay, so partial seizures. I'm going to look over here. So depending on what part of the brain their neurons are misfiring is what the seizure is going to look like. It could be in the motor area. So maybe they flex their arm or something like that. Maybe sensory area where they feel like the hair on their arms is sticking up. It might involve movement, problem solving, speech, hearing, consciousness, even things like language, not being able to speak properly, or maybe having to do with vision or perception. So you can see the brain's very complex. So depending on what part of the brain it's happening is what the seizure is going to look like. And hence the reason why you should document as much as you can so that the doctor may understand what you're seeing and understand their seizures more. So you might have gone to a neurologist and they diagnosed your loved one with epilepsy because they had a grand mal tonic-clonic seizure, used to be called grand mal. So, but then when you get home, maybe a few weeks later, they're also doing something else. So they might also be having partial seizures. So all these different things are really important to write down, keeping a diary. There are apps out there in the App Store that you can track seizures as well. So just keep an eye on all of that. It's like a puzzle that the doctor needs to put together. So these partial seizures, focal seizures, are the most common actually. So the grand mal tonic-clonic seizure that people fall to the ground, that's only 25% of all seizures. Most seizures are focal seizures happening in just one specific part of the brain. So focal seizures, onset aware. The person is aware of what's going on. They might have involuntary movements like twitching of the arms, the face, the legs. They might have sensory symptoms like tingling and weakness. They might smell things that aren't there. They might taste something in their mouth. They might see something physically that's visually that's not there. Or sometimes, it can look like anxiety. People have they're feeling they can't explain. So these last usually less than 1 minute, and they're often confused with acting out, mystical experience, mental illness, or psychosomatic illness. This is really important, because loved ones might say, well, not loved ones, but people might say, well, I think, you might have a teacher that says, I think she's faking because, the seizure looks like this. We can't count out anything like that. So we have to understand the person's medical condition and that it might look like something else. ADHD, acting out, mental illness, all these things. So, document. So the first aid for no change in consciousness, focal aware, stay calm, time the seizure, that's always the same every time. Make sure that they're safe, explain to others only if it's necessary because you want to protect their privacy. So sometimes people will say, oh, I have a tummy ache, a funny feeling. These can be focal seizures. Now, focal impaired awareness, we used to call complex partial, there is altered awareness. A blank stare, dazed look. They might pick at their clothes. They might say things that don't make sense. They might smack their lips. They might walk aimlessly or start to pick things up. These last 1 to 3 minutes usually, and it can also be followed by tiredness, headache, or nausea. This is often confused with drunkenness or aggressive behavior. Police officers get tripped up with this because they approach someone that's having this type of seizure, and the person, when they go to talk to that person, they can't answer because they're not aware. And if you go to grab them, they might lash out. So a lot of times people get arrested when they really have only had a seizure. So this gentleman here, he's having a seizure. So that is a little bit different from an absence seizure. It lasted a little bit longer, but it looks very similar. So that person, as they're having that seizure, probably is not aware of what's going on. Let's show you this.
Another common form of seizure that is not nearly as obvious is the complex partial seizure. Because only a small part of the brain is affected, a person
Oops, I'm sorry.
may still be able to perform gross motor skills like walking or sitting upright, yet be totally unaware of his or her actions. They may stare, mumble, repeat phrases, blink excessively, smack their lips, or pick at their clothing. However, they will be totally unresponsive to instructions because their consciousness is severely impaired.
Let's say somebody were speaking to me. I might remember none of it,
Kevin,
a little part of it,
Kevin,
or it might be all jumbled together.
Kevin. Can you hear me? Can you hear me?
It can look like something else. It can look like a student's not paying attention. It may look like a student is, using substances they're not supposed to be using.
I think it's important that a teacher not
So this is from our training that we do for teachers. So as you can see, Kevin was saying, but he probably could maybe hear just one thing. And then the other one, the guy was just wandering around. Oh, that's weird.
Another common form of seizure.
So first aid for impaired awareness, the focal impaired awareness, which we used to call complex partial. Again, time the seizure, speak softly and calmly, guide them away from any potential harmful objects, such as, things on a shelf that they might pull off. Allow them to wander in a contained area. If it's lasting more than 5 minutes, if that's what routine is, follow whatever emergency protocols the doctor has given you. Don't restrain or grab them. It might, because they're not aware of what's going on. Subconsciously, we're going to protect ourselves. So if you grab onto them, face right in front of them, they might push you, shove you, punch you. What you want to do, if you have to guide them away from something, maybe you want to guide them from the back or stand in front of what you don't want them to touch, because they will take the path of least resistance. So, they won't, that'll be fine, but you don't want to grab them. Don't shout to them and expect verbal instructions to be obeyed. So when is a seizure an emergency? It's a first-time seizure. It's lasted more than 5 minutes. It repeated seizures without regaining consciousness, more seizures than normal, or a change in the kind they have. Person has diabetes, is pregnant, it occurs in water, or the person's injured. So you got to follow what the doctor has requested. So here's some examples of it could be a seizure. Someone describes a seizure beginning with 30 seconds of an intense feeling that there's music playing. They can hear other people talking, but they couldn't respond. And afterwards, she really couldn't tell what they were saying. So afterwards, she's mildly confused and must reorient herself. So that's a seizure. A man has a seizure during which he remains fully aware, but the hair on his arms is standing on edge, and he has a feeling of being flushed. Perhaps a child stops what they're doing and stares at nothing for a moment or two. Or someone pays no attention when you speak loudly, call their name, or give an instruction. Common is rolling of their eyes, blinking fast, Sometimes it looks like they're on drugs. They might pick at their clothes. They might do things, if you know, that they don't normally do. It could be a seizure. Even a child falling for no reason. So let's just say you encounter a stranger having a seizure. You want to observe their normal behavior prior to the incident. Do they have automatic purposeless behaviors like picking at their clothes, picking at something, buttons that aren't there? They might do a chewing motion. They might mumble. Confusion, aware, clumsy, undirected violence. The guy that was walking down the street in the video I showed, he went into a store. He was shopping normally, and then he suddenly, these things came upon him. So he was fine right before, but then he started doing this. So he wasn't drunk, because, you know, you're gonna walk in drunk. So those are the signs you want to look for. Maybe ask bystanders if this if anyone knows this person, and do they have a history of epilepsy. Maybe they have a medical bracelet, or maybe they have epilepsy medication in their purse. So you want to look for that. So perform the seizure first aid we went over, call 911 if it's needed, and stay with that person until they return to baseline. Don't give them anything to drink or anything like that. Just return to baseline, have a safe way to get home. Sometimes you think they're at baseline, but they're actually not. Someone had a seizure in one of my support groups, and the husband said, well, we'll leave here in 20 minutes. And I was talking to her, and I said, oh, she looks fine. And he said, no, she still doesn't know what her surroundings are right now. And then it'll take 20 minutes for her to get back. I'm like, oh, that's amazing. I didn't realize. And then he proceeded to ask her questions she didn't know the answer to, that she would have, like, who's the president or something like that. So once you get diagnosed with epilepsy by a neurologist, the doctor's first going to try AEDs, anti-epileptic drugs. That's the first thing. And if it's not working after 3-4 times, different meds, they might look at surgery, whether or not they can remove that part of the brain, maybe the ketogenic diet. And last, there's some neurostimulators like the vagus nerve stimulator devices that get implanted. These are common medications. More than 50% of newly diagnosed epilepsy, they become seizure-free with one medication. About 75% of those with epilepsy have seizures that are well controlled on medication. So the issue is the ones that the medicines aren't working for. It's about a third of all people. They're having breakthrough seizures or seizures that are just not well controlled. Of course, we don't want that. The goal is no seizures, no side effects. So the medical marijuana, I don't know anybody that's on medical marijuana. Maybe someone has someone that their seizures are not under control. Obviously, you're going to, it's not controlled by the FDA, so dosing's an issue. Just talk to your doctor about it. Don't go off and do anything on your own. It could interact with the epilepsy medication, but you're not missing out on anything if you haven't tried it. I don't really know too many people that with epilepsy that are trying it. Now, people are trying it for anxiety and other things, but I don't really see it for people with epilepsy. You might be aware of rescue medications. The one that it used to be in all the schools for people with epilepsy was the Diastat. It's a rectal gel. It's kind of invasive, but now they've come out with some wafers and some sprays. These midazolam nasal spray and the diazepam nasal spray. They're both relatively new, and it's sprayed into their nostrils. It's so less invasive. Doctors and neurologists are turning away from Diastat, the more invasive, and turning to these nasal sprays for the nurse to have in the nurse's office for when that child has a seizure that's not stopping. Common side effects for medications. These are ones, they have cognitive problems, dizziness, coordination. Sometimes there's mood changes. There's one medication that's Keppra that works really well. It's the first line, like doctors go to that medication first. It works great, but for some people it causes mood changes where they get angry. So, keep an eye on all those different things. And again, I say keep a log. Make sure you know everything when you get in that doctor's office. It's so important to have everything written down. Surgery, if those medications aren't working, a third of those people, the doctor might say, let's try, let's look at the brain and see where these seizures are originating from, these focal seizures. Can we successfully remove that particular part of the brain that's causing the issue without sacrificing quality of life? So they'll look at that. They do all sorts of tests. They map the brain, MRIs and SPECT scan and PET scans. So they might have, here's some of the procedures: focal resection, lobectomy, hemispherectomy. So these are some of the procedures. A lot of times it's getting less and less invasive, the surgery procedures. And so a lot of times people can go home after a short stay in the hospital. If surgery is not an option, then they're going to look at the ketogenic diet. This is the fad, the ketogenic diet. It's a diet high in fat and low in protein and carbohydrates. This type of diet is inflexible. You can only eat certain foods. You have to measure them out. You can't cheat like a diet. So it really shouldn't be called a diet because you'll have seizures. So it's very difficult. Obviously, it's not the best diet. So doctors usually take someone off of that diet if they're successful after 2 years. And there's some of the side effects, kidney stones and things like that. So if the ketogenic diet's not an option, the vagus nerve stimulator. This is, it's not, if you have one of these, you also need to be on medication because it's not the answer for everything. What it does, it's implanted in the chest wall, the left chest wall. Then there's a coil that runs up the vagus nerve and into the brain. And this lead generates pulses of electricity to stimulate at certain times. Like maybe it'll be 1 minute on, 3 minutes off, 1 minute on. You don't know what's going on and off. So it's implanted under the skin. And what it does is doesn't usually remove seizures. After a time, it might reduce the number of seizures, reduce the length of a seizure, and people report a better quality of life after having this implanted. So what happens is if they feel like a seizure's coming, which a lot of people do not know when it's coming, they can swipe this magnet that we show here over the VNS to give an extra burst of stimulation to the brain. So like I said, we don't know if it's on or off, but if a seizure's coming in or you see somebody in a seizure, you swipe that and it automatically turns on. It'll turn on if it's off or it will stay on. So usually you don't want to do it more than once a minute because you want to let it run that minute. So you can read more about it at vnstherapy.com. There's some new emerging sort of other medical devices, responsive neurostimulation. Neurostimulators are placed under the scalp, and it's usually for people with just two seizures originating from 2 places. Same with the deep brain stimulator. Electrodes are planted in certain areas of the brain, and that same thing up to 2 leads. So I see a lot of VNS. I haven't seen too many RNSs and DBSs yet. When I first started 13 years ago, I didn't see a lot of VNS, and now I do. So I might just need time to get to the general public. So I can give you all these forms when we're done. If you've signed up, the next day, that might be helpful for you. One of them is the seizure observation record, what to look for in a seizure, what the person was doing right before a seizure. Like maybe they were watching TV, or maybe they were taking a walk, or working out, or whatever it might be. These are important clues because they might have a seizure trigger. So you want to write that all down. You want to document how long it's the seizure's happening and what it looked like. Seizure action plan, everyone should have one. We see them in the schools a lot for the students, but everyone should have one on their fridge in case an ambulance comes. You can hand that to the ambulance to give to the doctor. What they're on, and what medications they're on, who to call, that sort of thing. And that's developed by the neurologist, and it's approved by everybody. It provides basic information about their seizures, first aid. So you want to give that to whomever. You might even want to think about calling the local ambulance company, letting them know that your loved one has epilepsy, and at some point they might be called to come help. And let's handle it this way. Because of COVID, we wanted to the hospital action plan. Sometimes your loved one's admitted in the hospital during the pandemic. They might not be able to go with them to the hospital or visit them in the hospital. So be proactive. Talk to the neurologist about prescribing a rescue med, like those nasal sprays, so that a caregiver can give that will avoid the hospital. If you need to go to the hospital, make sure the EMT is given the name and dosage of that medicine. They should take their medication with them in the original bottles. Someone said to me, why not? What I tell people is to pin the seizure action plan to the loved one's shirt so that the doctor can see it when they get there. Create a hospital plan that has the diagnosis, the description of what the seizures look like, what they're like after the seizure. You need to list all their dosage and medication, include information about any VNS or any other implants, so allergies and all that kind of thing. So talk to your doctor about that. That was a real issue where we couldn't go and visit our loved ones. And you want to, you're not there to tell the doctors what's going on. This is pretty much the same thing. Keep a copy. What I said, keep on the refrigerator, put it in a plastic bag and pin it to the patient's clothes if they're getting in the ambulance. So basically, we're here to help. So we know that there's challenges for you, your families, the individuals that are living with epilepsy, side effects, looking for healthcare providers, caregiver stress, stigma, isolation. We're here for you to help you in any way we can. So that's our contact information. That's our phone number. My name is Ellen Baca. You don't have to live in the Lehigh Valley to contact me. You'll see me on our website. Our website is efepa.org, Epilepsy Foundation Eastern PA. So we'll do training, advocacy, support for the epilepsy community. All of the things that we do are for free. So we'd love to help you in any way we can. So let's see what kind of questions we have here. Is there always shaking during a seizure? How can these be diagnosed when they last only a few minutes? So there isn't always shaking. Like the video, the videos that I showed you, they could be wandering aimlessly. They could be sitting and staring off. So really, the shaking ones are only about a quarter of all seizures. Those are the Tonic-Clonic seizures that we, like the dramatic ones we see on TV. There's no mistaking that that's a seizure. They fall into the ground and they begin to shake. Other seizures are more subtle, and that's where education is so important, because they can be missed. So some of the clues that I had laid out, you want to look for movements that make no sense, or rolling of the eyes, or when you talk to them, they're not answering. So hopefully this has helped a little bit. What normally happens when people I've seen this where someone says, I'd have these moments where I would zone out. And it just happened, like I'll be watching a TV show and then all of a sudden it's the end of the TV show. I have no idea what happened. So they said that they were having this for a while. They didn't realize, most people do not realize these different types of seizures. It took a grand mal tonic-clonic seizure for them to be admitted to the hospital. Then the neurologist comes in, they do an EEG, they see abnormal brain waves, and you talk to the doctor and say, I've had these incidents in the past. They see that you have abnormal tests for the EEG. They might just diagnose you with epilepsy, even with just that one seizure, because there's other obvious signs that seizures have been taking place.
Ellen, Linda said her daughter had the RNS implant last year and it's helped to reduce her seizures. So that's
wonderful.
Good news. And Pamela said, thank you for the vital information, which you have supplied.
This ghostly person that's talking is Mary.
Who came in late. I am so sorry.
No problem. She works in the Wilkes-Barre area, doing the same thing that I do. She actually has a son with epilepsy, so she's got all that experience there. But yeah, so that's the person lingering in the background.
Yeah. And we do have, as Ellen said, support groups, and we're doing them I don't want to say fortunately by Zoom, but that way everybody could attend. So we have them for parents, we have them for the families. So please feel free to join them. You'll get a lot of good information. You'll meet other people experiencing what you are experiencing.